When you look at intermittent claudication, it's um, fascinating how two conditions, vascular and neurogenic, can present with such similar symptoms, yet stem from completely different mechanisms.
Yeah, exactly.
Right, so on one side we have vascular claudication, primarily due to poor blood flow from occlusive arterial disease, and on the other there's neurogenic claudication, which is all about nerve compression from lumbar stenosis.
Definitely.
And it's like the clinical presentations share that hallmark of exercise-induced leg pain relieved by rest, but the relief mechanisms are totally divergent, right?
Very different indeed.
Exactly. Vascular claudication pain is usually predictable, coming on after a set walking distance, then easing within a few minutes once you stop, whereas neurogenic pain can be a lot more variable and is often significantly improved by lumbar flexion, like leaning on a shopping cart.
Yes, that shopping cart trick is such a classic indicator.
Now, if we dive into epidemiology, vascular claudication, often due to peripheral arterial disease, tends to occur in older populations and those with risk factors like diabetes, cigarette smoking, dyslipidemia, and hypertension.
Mm-hmm. And those risk factors really overlap with coronary artery disease factors.
Right, and the numbers are striking. Around 5% of individuals older than 50 show symptomatic disease, but that jumps to nearly 20% in septuagenarians.
Yep, that's quite significant, especially when interpreting screening results.
In contrast, neurogenic claudication, mostly seen with degenerative lumbar spinal stenosis, appears typically in those aged 60 and above, with a prevalence that even reaches almost 14% in octogenarians.
Yeah, and what's interesting is how the occupational history, like long-term manual labor, factors in.
Absolutely. It's fascinating because while vascular claudication is rooted in atherosclerosis and its systemic risk factors, neurogenic claudication is more about mechanical factors, disc bulging, hypertrophy of the ligamentum flavum, and facet joint osteophytes.
Exactly.
When we consider pathophysiology, vascular claudication is essentially a supply-demand mismatch. During exercise, the stenosaid vessel can't provide enough oxygen to the muscle, leading to anaerobic metabolism, lactate buildup, and
Right
pain.
on. It's like the muscle is literally screaming for more oxygen.
Yeah, and the mathematics here is neat. Poiseuille's law really explains it, since the blood flow is proportional to the fourth power of the vessel's radius.
That exponential effect really underpins how a small narrowing hinders flow massively.
On the flip side, neurogenic claudication involves transient neural ischemia that's triggered by lumbar extension. This extension decreases the canal diameter and compresses the neural elements, which explains the relief when patients flex their spines.
Right, that relief upon flexion is pretty diagnostic.
It's interesting, though. Chronic ischemia in PAD can also eventually lead to neuropathy, so sometimes the symptoms can intertwine.
True, but I do wonder sometimes if attributing a patient's leg pain solely to one cause can be misleading if the picture isn't clear.
Sure, and that's where precise physical examination becomes critical. In vascular claudication, checking peripheral pulses, skin changes, and an abnormal ankle brachial index, ABI, really guide diagnosis.
The ABI is such a quick yet valuable tool.
Exactly. An ABI below 0.90 is pretty indicative of significant arterial disease. And then you have the role of imaging, CTA, MRA, to delineate the occlusive
Yeah, and even
lesion.
digital subtraction angiography, although that's reserved, especially when planning interventions.
Meanwhile, with neurogenic claudication, neurological exams are the cornerstone, finding sensory deficits in L4 to S1 dermatomes, diminished reflexes, and even gait assessments.
Absolutely. A careful neurological exam can reveal so much about potential lumbar nerve root involvement.
I love how there's a neat functional test, too, the bicycle test of Van Gelderen. It smartly differentiates between the two by having patients pedal upright versus leaning forward.
That toggling posture is really clever.
Right, because neurogenic claudication typically presents faster when the lumbar spine is in extension, whereas the vascular counterpart remains relatively unchanged with posture.
Yep, that shift with flexion is almost like a built-in diagnostic tool.
The discussion on management is equally intriguing. For vascular claudication, lifestyle modifications like smoking cessation and supervised exercise are key, alongside medications like aspirin, statins, and even
Mm-hmm.
cilostazol.
Lifestyle changes really do have a huge impact here.
Right, and some patients even see improvement with revascularization procedures such as angioplasty with stenting, especially if their symptoms persist despite conservative management.
Yeah, although there's that balance between systemic therapy and intervention that we have to consider, huh?
Exactly. If you miss the diagnosis, you either risk limb loss or subject patients to unnecessary procedures for the wrong diagnosis.
Totally. Misdiagnosis can have serious ramifications on both outcomes and quality of life.
Then there's the non-operative management for neurogenic claudication. Education, physiotherapy, NSAIDs, and the option of epidural steroid injections are all first line.
Mm-hmm. And I remember that surgical decompression only comes into play when conservative measures fail.
Exactly. It's a delicate balance, especially when you're treating older patients with comorbidities. Decompression surgery can yield excellent results, sometimes achieving up to 80% durable relief in appropriately selected patients.
Yes, though. You know, I sometimes wonder if our thresholds for surgery might be a bit too aggressive in borderline cases.
That's a fair point. In practice, algorithms now advocate a stepwise approach, first evaluating with ABI, then lumbar MRI if neurological signs predominate, and if things are ambiguous, then a combined workup is warranted.
Mm-hmm. That sequential method really helps to minimize risks of misdiagnosis or overtreatment.
It's almost like solving a diagnostic puzzle, isn't it? You have to piece together history, physical exams, imaging, and sometimes even treadmill protocols to pinpoint the root
Absolutely.
cause.
And each piece of evidence can really change the treatment plan.
Speaking of treadmill protocols, there's that interesting distinction. Using different gradients and speeds can uncover subclinical vascular insufficiency versus a predominantly neurogenic origin, making it a functional test with real diagnostic heft.
Mm-hmm. It's amazing how just a slight change in incline or speed can reveal so much.
Right, and that ties into the overall prognosis. For vascular claudication, while the limb is rarely threatened solely by claudication, it's more of a marker for widespread atherosclerosis and a higher risk of cardiovascular events.
Right, the 5-year mortality statistics really underscore that systemic risk.
In contrast, neurogenic claudication rarely leads to catastrophic nerve damage but can severely impact quality of life due to falls, deconditioning, and chronic pain.
Yeah, the disability from neurogenic claudication can be profound, even if it's not life-threatening in the same way.
It's that dual focus on restoring function and mitigating risk that makes proper diagnosis so crucial. Plus, as our imaging techniques improve, like dynamic, time-resolved MRA and positional MRIs, we're getting better at tailoring treatment to individual patients.
Mm-hmm. Those emerging imaging techniques really add a new dimension to our understanding.
Right, and what excites me is the potential for novel therapies. Think pro-angiogenic gene therapy for PAD and biologic modulation of disc degeneration for spinal stenosis.
That's a promising horizon, though I do wonder about the long-term outcomes.
Exactly, there's promise, but also challenges. Robust clinical trials are needed to truly validate these emerging treatments.
Mm-hmm. It's a field ripe for investigation and innovation.
There's also that interesting point of overlap. Patients, particularly smokers with diabetes, might show mixed features where peripheral arterial disease and neuropathic elements combine.
Right? Which further complicates treatment decisions, calling for more integrated diagnostic approaches.
Yeah, and that's why a multidisciplinary approach, cardiovascular surgeons, vascular and spine specialists, neurologists, becomes critical to avoid misattributed symptoms or unnecessary interventions.
Absolutely, collaboration really is the key to nuanced management.
When you take a step back, it's all about patient outcomes. For instance, aggressive cardiovascular risk management combined with revascularization can dramatically improve limb outcomes, while tailored decompressive surgery can restore mobility for spinal patients.
Mm-hmm. Both strategies have their place based on the individual patient's profile.
One of the cases discussed really illustrates this well. A 65-year-old man with classic PAD who, after supervised exercise and medication optimization, eventually needed stenting to walk further without pain.
Yeah, that case exemplifies the importance of a stepwise, evidence-based approach.
And then there's the elderly patient with lumbar stenosis, who benefited immensely from a minimally invasive laminectomy, helping her regain a quality of life that otherwise would have declined sharply.
It really highlights how proper intervention can restore independence.
It's remarkable how the same symptom, leg pain, can lead to such divergent pathways, one of systemic cardiovascular risk and the other of spinal mechanical dysfunction.
Absolutely, which is why the diagnostic algorithm, starting with ABI and moving to targeted imaging, is so essential.
I sometimes question how firmly clinicians can differentiate the two when the clinical exam finds borderline results, especially with calcified arteries or incidental lumbar findings.
That's a valid point. Sometimes the overlap challenges even the most experienced practitioners.
And that's why a sequential, algorithm-driven approach, along with multidisciplinary team assessments, remains our best strategy to manage these complexities and optimize patient outcomes.
Indeed, it ensures we're not treating a symptom, but working on the underlying cause.
So, ultimately, the key takeaway is that while vascular and neurogenic claudication may present similarly, understanding their distinct epidemiology, pathophysiology, clinical markers, and management strategies is crucial for preserving both limb and nerve function while enhancing quality of life.
Absolutely. And it's exciting to see how ongoing research and innovative imaging techniques are continuously refining our approach.
Yeah, it's a dynamic area where our insights directly impact patient care, reminding us that even subtle differences in symptomatology can mean vastly different therapeutic avenues.
hmm Learning and adapting remain at the heart of effective treatment here.